next up is going to be our keynote speaker, Dr. Aminta. I'll let you shut off your own video. How about that? I love your comfy room. All right. So next we are just looking for our speaker, Dr. Jessica Tate. Dr. Tate, are you on yet? I do not see her yet, so we're just
here.
There you are. Hi, good morning.
Hi. Good morning.
So we're so lucky to have Dr. Jessica Tate. She is a movement disorder specialist from Wake Forest Baptist Medical Center in the movement disorder area there. She has received her bachelor's at College of William and Mary. She received her MD at West Virginia University School of Medicine. She did her movement disorders fellowship at Wake Forest Baptist Medical Center. So weren't they lucky that you did your fellowship there and you stayed with them? This is awesome. And Dr. Tate has been a speaker for us before. She's lovely, wonderful. We greatly appreciate, again, you being here this morning. And I'm not going to take up any more of your time, and I'm going to go ahead and let you start. Thank you.
Okay, thank you so much for having me. I'm going to pull up my presentation here. Give me just a moment. And can you all tell me if you're not able to see it?
I can see it.
Okay. Okay. And I'm going to adjust one more thing here on my view. Give me just a minute.
While you're doing that, I'm going to remind everyone that as Dr. Tate goes through her presentation, if you think of questions, go down there to the bottom of your screen in the middle where it says chat and put questions in there, and we will be monitoring those. At the end, we're going to have 10 minutes for a Q&A. So Dr. Tate, you have about 40 minutes.
40 minutes. Okay. I'll try to keep some eye on that.
No worries. We'll help.
Okay. Well, like I said, thank you so much for having me. I'm excited to be here this morning. I wish things were a little different and we could be with each other in person. It was great to have that little yoga practice before I had to speak. That was kind of rejuvenating this morning. So Aminta, I appreciate that. So I'm gonna talk about just some updates on treatment options and some updates on research. And at the beginning, I thought I would just do a brief overview of Parkinson's disease. I know some people attending today are probably newer to the journey with Parkinson's. You may have been recently diagnosed. You may not have had too much of a chance to kind of sit down with your doctor and have like an education session about Parkinson's. So just to kind of get us on the same page, just some of the stats, I guess, some of the epidemiology of Parkinson's. So why? I mean, that's a big question and still a big focus of research. And, we certainly don't have a full understanding of it by any stretch. We do know that men are more likely to develop Parkinson's, about 1.5 times. I get lots of questions about genetics. And, is Parkinson's something that's hereditary that I could pass on to my family? And in general, we think that about 10% of cases are hereditary in the sense that they're kind of directly passed on from one generation to the next due to a genetic mutation. But about 90% of cases are more complex. So they're what we call sporadic. And we think that, like many things, and that could include, high blood pressure or diabetes, but like many things, it's kind of a combination of genetics and environment. So, people may have sort of a combination of genes that put them at risk for developing Parkinson's, but then, there may be something that they're exposed to in life that then kind of triggers that ball rolling. and actually starts the process. And some things that have been, clearly associated as risk factors. I mean, age is the biggest. As people get older, they're more likely to develop Parkinson's. And then exposures, like chemical exposures. So people working around jet fuel, solvents, like in the dry cleaning industry, pesticides and herbicides, in, farming and gardening. And then there are some things that may be protective. Caffeine is thought to possibly be protective to the brain. That's good for me. Smoking, which I'm not advocating by any stretch. But interestingly enough, there is a suggestion that smokers may be somewhat protected. Now, smokers may be at risk for developing a different type of Parkinsonism called vascular Parkinsonism that behaves a little bit differently due to kind of damage to blood vessels over time. But as far as idiopathic Parkinson's disease, it may be protective. Exercise, being physically active, and possibly people that have gout, because they tend to have higher uric acid levels in their blood. So what is Parkinson's? I mean, kind of our definition as neurologists, when we are taking a history from an individual, examining an individual, the things that we're looking for as far as motor features, so kind of movement related things, kind of overt things that we can appreciate on exam. The hallmark features are bradykinesia, which is kind of a combination of slower movements and smaller movements, kind of a decrement in things. So people may start out with their movements being pretty large, and then it dies down. Rigidity of the muscles, which we can feel when we move someone's arms and legs. Tremor, which sometimes is the predominant symptom that someone has and the first symptom that they have, and sometimes is absent altogether. Some people never develop tremor. Excuse me. And that can involve different areas of the body. It can involve the arms, probably most commonly one arm or both arms, the legs, and sometimes the chin or the jaw. And then the fourth thing is something that generally would come along kind of later in the course of Parkinson's, not a first or an early symptom, but that is postural instability. And, that's basically a fancy way of saying poor balance. And one of the ways that we test for that in the clinic setting is we have people stand in the hall in front of us and we tug on their shoulders. And we check to see if they're able to maintain their balance, their upright posture, or if they have this tendency to kind of fall back toward us. And then there are lots of, and sorry, this is an error on my slide that I just saw. So these are non-motor symptoms of Parkinson's. So there are lots of those. So, these are not the overt things that people can see. But these are also things that can cause a lot of disability. So mood changes, like depression and anxiety, just kind of loss of interest or motivation due to some of the changes in the brain. So what we call apathy, difficulty sleeping, disrupted sleep, what we call REM, sleep behavior disorder. So when people are dreaming, they're able to act out their dreams, like yelling or punching or kicking. Psychosis, hallucinations or delusions. That's the feature, I guess, that typically we see in more advanced Parkinson's. It may end up happening to about 50% of patients at some point. But psychosis is not something that happens to everyone. And then autonomic dysfunction. So that's, the part of the nervous system that is supposed to regulate some of our automatic bodily functions. So, some big ones would be like our breathing, our blood pressure, our sweating, and things like that. And so we can see issues with things like orthostatic hypotension, which are fluctuations in blood pressure, drops in blood pressure when people change position, and changes in kind of hot and cold tolerance and things like that from autonomic nervous system dysfunction. Fatigue is a big one and frustrating one that's very common. And sometimes unintentional weight loss. And sometimes that's, there's kind of a more obvious explanation for that because people, do have involuntary movements as part of their course of Parkinson's. So if people have, severe tremor, or they have levodopa-induced dyskinesias, which are, kind of involuntary rocking or swaying or kind of writhing movements, that's burning calories. So that part makes sense. Sometimes we're not really able to understand why people are losing weight. But we try to, forestall that as much as we can. So another, question that I frequently get in clinic is, you haven't really done any tests. So how do you know that I have Parkinson's? And that's a very good question. At this point, there is still no definitive test, for Parkinson's. It is a clinical diagnosis. So that means, we're basing it off what we hear about a person's story, the symptoms that they're experiencing, and a detailed neurological exam. And the things that we're looking for on that neuro exam are exactly the things, that I mentioned on that motor symptom slide. We're looking for maybe a hallmark type of tremor, a resting tremor. When the arms and legs are relaxed, we're looking for rigidity. We're looking for bradykinesia. We're looking for maybe some even subtle changes in the way someone walks, like not swinging an arm as much as the other, or not taking as big a step on one side as the other. So those are the things we're looking for that clinical diagnosis. And there is, a criteria that's been established by the experts over the years. Now we may still do tests. We may do tests to rule out, other things that can sort of mimic Parkinson's. One thing that I mentioned right at the beginning was vascular Parkinsonism. So that's when, like I said, kind of this accumulation of damage to the blood vessels in the brain. It's kind of caused this progressive change and damage over usually a period of years. And that's something that shows up on an MRI scan. So sometimes if we have a high suspicion that this might be the vascular form, like I said, it does behave a little bit differently. We may want to get a brain MRI to rule that out, but the MRI itself does not show us Parkinson's. And then, we may also do some blood work. So young patients in particular, we probably end up doing more because there are maybe more things in that age group or population. There are more things that could maybe potentially mimic Parkinson's. So, doing blood work, looking at copper metabolism to rule out Wilson's disease or something of that nature. But sometimes we really don't do additional tests at all. Like if the history and the examination that we're doing on a patient are consistent, then that it may stop there. The last thing I'll mention is a DAT scan, and that is an additional test that we sometimes obtain to get support. I mean, I don't think we would never solely base a person's diagnosis on a DAT scan, but it is something where if maybe we are uncertain or there are some, extenuating factors in the picture that are a bit kind of confusing things, then we may get a DAT scan. And this is an example of what the DAT scan looks like to us after it's completed. So it's obviously, it's very different than a brain MRI. It's not pictures of the brain per se, like where we're seeing the detailed structure of the brain. This is showing us the areas basically that are lacking dopamine. So a person is given a tracer through an IV, and then it's a radioactive tracer. That tracer binds to these specific areas deep within the brain, the caudate and the putamen. And those are areas that are impacted by dopamine loss. And As we now know, really the motor and non-motor symptoms of Parkinson's are largely driven by this lack of dopamine in the brain, this degeneration of the dopamine producing brain cells over time. And so this basically is a scan that picks up on that dopamine loss. It is FDA approved and kind of technically marketed by GE to differentiate between, idiopathic Parkinsonism and essential tremor. And we sometimes use it for that context, but usually kind of one of the big differences between Parkinson's and essential tremor are just the characteristics of the tremor itself. So they're kind of opposites of each other. An essential tremor is an action or postural tremor. So when somebody holds up their arms or extends, moves their arms to pick up a coffee cup or to write, there's a significant amount of tremor. And then, as we know, the classic Parkinson's tremor is a resting tremor, typically when the hand is relaxed and not moving. So when we examine somebody, we're kind of looking for those features, and they're opposite enough from each other that in a lot of cases, it's easy to just tell the difference from an exam. But if it's not, this DAT scan is something that we can utilize. I also sometimes personally order it if somebody is on medications that could cause the signs or symptoms of Parkinson's disease. And those are usually psychiatric medications. So they're in a group called antipsychotics, or sometimes medicines that people are taking chronically to treat nausea. And those can kind of cloud the picture and cause sort of this Parkinson's-like appearance when it's not truly Parkinson's disease. So in that situation, we're expecting not to see that dopamine loss like we do in Parkinson's. Now, a big limitation of the DAT scan, this last little paragraph, it does not differentiate among Parkinson's and other types of neurodegenerative Parkinsonism, where we also see dopamine being lost, dopamine cell loss. And those are, we kind of tend to group those diseases as atypical Parkinsonism. And those include things like progressive supranuclear palsy or PSP, multiple systems atrophy or MSA, corticobasal degeneration or CBD. And like I said, those are things that can kind of look like Parkinson's, but do behave differently. And unfortunately, like I said, this DAT scan doesn't help us tell the difference between, things within that group. So now that we've had our overview kind of the basics, the background of Parkinson's, I thought I'd just review, kind of medication choices and probably try to focus most on things that are relatively new that have come out to market within the last couple of years. As you can see here, it's hard to say there's any right or wrong answer when it comes to, initially treating Parkinson's when people have pretty mild symptoms. Usually, we don't necessarily treat at all with symptomatic medicines unless people are really beginning to, maybe develop some disability from their symptoms. It's limiting the things that they want or need to do. Or the symptoms are just an extreme nuisance, like tremor, for example. So, if the symptoms are bothersome and disabling, then we'll usually elect to go ahead and start a medication. But we have a lot of choices. So you can see we can use MAO inhibitors, which, kind of have mild symptomatic benefit. The ones that we have out now are rasagiline and selegiline. Anticholinergic medications are sometimes used for tremor. The most common ones that we use are benztropine and trihexyphenidyl. We can use dopamine agonists, and we have 3 of those: pramipexole, ropinirole, and rotigotine. Rotigotine is a patch. The other 2 are pills. And then some people even get started on amantadine, which is a medication that's been around for a long time and used for Parkinson's. And we think it has some antagonism of NMDA, which is a receptor in our nervous system. But there's actually still things we don't really understand about the mechanism of amantadine. So, early on, people may get started, like I said, on one of those categories. They may also get started on carbidopa levodopa, and there are multiple kind of forms or brands of carbidopa levodopa that are out there now. Probably the most common that we refer to is Cinemet. And depending on a person's age and depending on kind of how significant a person's symptoms are at the time of diagnosis, like I said, they may get started right away on carbidopa levodopa. And, I would say just as time goes on, as years go by, we're following a person, probably at some point we're going to transition over. For most people, we're going to transition over at some point to using carbidopa levodopa, because even though it's been around for a long time, it is still kind of considered our most effective medication. It has, kind of the most bang for its buck. It's kind of its intention is to basically directly replace dopamine that has been lost in the brain. And usually people started on carbidopa levodopa will have kind of what we refer to as a honeymoon period. So, the carbidopa levodopa is control, at least partially controlling their symptoms, and it's kind of easy to take. Usually people are taking it like probably 2 to 3 times a day. And then we tend to reach this point in Parkinson's where it's not as simple and straightforward. People can start to develop what we call medication fluctuations. And those are when people are having like ups and downs. So, they may take their dose at 8 o'clock in the morning and are due to take another one at noon. But by 11, they actually feel like the medication is wearing off, and it's kind of, their symptoms are returning and their symptoms are worsening. So they're having wearing off periods. And they may have the opposite issue, which are the dyskinesias. So as the medication is kind of at the peak in their system and the dopamine is at its highest level, and when it's working, they might have, these involuntary movements, these dyskinesias of their body. And so usually when people reach that stage of things where they're having medication fluctuations, we may change up, what we do. And I mean, one thing we can change is just to adjust their carbidopa levodopa schedule. So we may, space it more closely together. We may have them take more doses, within their waking hours. Or we may have them take a bit more at one time. But, if that's kind of difficult to manage for one reason or the other, we may use add-ons. And so some of the things that can be added to carbidopa levodopa to help it last longer in a person's system and to try to sort of smooth things out, are actually some of the same categories of things that I mentioned earlier that can be used on their own. But in this case, we're using them to kind of help the levodopa. So one of the newer drugs that's been out for a few years now is Zavago or safenamide. So that is one of the MAO inhibitors, but it's only been approved as an add-on to levodopa. So we still have the rasagiline and the selegiline, but we have this one called safenamide. And we can use the dopamine agonist as well, in addition to levodopa, those same ones, pramipexole, ropinirole, the rotigotine patch. A category that is specific as just an add-on to carbidopa levodopa are the COMT inhibitors. So those literally prevent the breakdown of levodopa and help it stick around in the system longer. And so they're only worthwhile when they are dosed along with levodopa. And so we have one called entacapone. It's been around for, a good while now. It's available as a separate pill that people take with their carbidopa levodopa, or there's a combination pill called Stalevo where you can take all three. The new thing that's been out much more recently is called opicapone or Ongentys. And that is like a long-acting version of a COMT inhibitor. So it is one that is taken just once a day. but with the same purpose, to help kind of extend the carbidopa levodopa doses. So there's definitely the convenience factor there of potentially taking fewer pills per day. One issue that unfortunately we tend to run into with the COMT inhibitors is if people have dyskinesias, just because it is elevating the level of the dopamine, it can make those worse. So sometimes we're limited in our ability to use those, because they can flare up dyskinesias. We've got some others. So there's a extended release version of carbidopa levodopa called Rytari that we sometimes utilize in this situation, that sometimes allows for people to take the medication fewer times per day and stick to more like 3 or 4 doses per day, as opposed to escalating doses. And this is another newer one to the market, an adenosine receptor antagonist. This was the first in its class to be developed. So it's a new class. Istradefylline, or Norians. So again, that is one that can be utilized as an add-on to levodopa for people that are having wearing off. I think I duplicated that one. Sorry, the COMT inhibitors. And then we've got amantadine. And so the new thing about amantadine, it's been around, like I said, for years. GoCovery, which is a newer version, a newer extended release version of amantadine that people take once per day in the evening. The GoCovery was recently given kind of a new indication. So its original indication was to reduce levodopa-induced dyskinesias. Its newer indication is to actually reduce wearing off. So it can be utilized for that purpose as well. And then this is unfortunately, this is a big limitation, I think, in treatment of Parkinson's. We only have this one particular drug, these different forms of amantadine, to directly address the levodopa-induced dyskinesias. So that's kind of the one add-on we have that is specific to being able to reduce those excessive movements. So we've got either, the standard version that people usually take 2 or 3 times a day. And then we have, like I said, the newer version, the GoCovery, that people take in the evening. And then we have kind of a different group that we refer to as rescue medications. So these are medications that people can utilize with rapid onset of benefit. So if they're having an off period where they feel like their levodopa has worn off, their symptoms have gotten worse. Some people can have fairly severe symptoms during these off stages. So rather than waiting for their next dose of levodopa to kick back in, they can use one of these rescue medicines. And the one that we have had available for a long while now is Apokyn. So it's a form of apomorphine, and the Apokyn is an injection. So people give themselves an injection under their skin during one of these off periods, and have rapid onset of benefit. So there's supposed to be benefit within around 10 minutes or 10 to 15 minutes. The new addition to that crowd is Kinmobi, and Kinmobi is also apomorphine, but it is a sublingual form. So there's a strip that goes under the tongue and dissolves, and that's just another delivery system. So I've had quite a few patients trying out the Kinmobi here of late. And I think people that had, some aversion to the idea of injecting themselves, have maybe been a bit more keen to think about the under the tongue strip. And then there also is an inhaler. So there is an inhaled type of levodopa, comes in a little capsule. The capsule goes into an inhaler, and the inhaler kind of breaks the capsule open, and then people inhale the contents into their lungs. It's called Inbrija. And same concept. I mean, people would usually not use this as their main form of levodopa necessarily, but could use actually any of these three things. Could use like first thing in the morning before medication is in their system to kind of give themselves a kickstart, or otherwise use kind of in between their doses of oral carbidopa levodopa when they need it, just kind of on demand. Most of these, like the Kenmobi specifically, I know can be used up to 5 times within a day. So most of them have that kind of allowance. And then that brings us, so, you know, if despite our efforts with the medications, with those oral medication groups that I just went through, if despite our best efforts, people are still having a lot of ups and downs, you know, they're having wearing off in between doses, and, you know, some of these add-on options either haven't worked or are causing side effects, then we may start talking to people about surgical options for Parkinson's. And, you know, Duopa has been FDA approved for several years now, but I still encounter a lot of individuals with Parkinson's that aren't familiar with it, or really haven't heard about it or much about it. So Duopa is a pump system. It does require a minor surgical procedure to place a G-tube into the stomach. And so that means that there's an internal portion, it goes through the skin of the abdomen, and then there's an internal portion, and you can see on the screen, like there's a little piece of tubing that goes through the stomach and to the first part of the small intestine. And then there's an external part, you know, that protrudes from the skin, a segment of tubing.
Fine, yes.
And that allows people to connect this pump system. The pump system contains cartridges of carbidopa levodopa. So it's still, you know, the same medication, but it's in like a gel form in a cartridge that pops into the pump. People, you know, connect that to their tube, turn it on, and then they kind of go for the day. And their medication is, so their carbidopa levodopa, they're no longer taking by mouth, by pill form. The medication is delivered continuously through this pump system throughout the day. And it's FDA approved for use for 16 hours, like during the daytime. Most people disconnect it at night and take, you know, the pump section off. And, you know, it is, I mean, I would say advantages, you know, the procedure itself is a relatively low risk procedure, although, I mean, it is an invasive procedure, but it's relatively low risk. It's easily reversible. And, you know, it does increase on time. It may be available to people that aren't candidates for brain surgical procedures because they're considered high risk for one reason or the other. You know, so those are all upsides. Downsides, I think potentially just the idea of having something external to transport. You can see I put the example of the gentleman wearing like the almost fanny pack, you know, waist pack to hold it in. They also make a shoulder carrying case. They also make a vest. So there are different ways to transport it. But this is, you know, this is an option to be aware of if medications alone are not sufficient to control symptoms, if oral medications are not enough to control symptoms. And then that brings us to deep brain stimulation, which is our other surgical procedure for Parkinson's. Our two main reasons for doing deep brain stimulation are somewhat different. So we may do it for an individual who has tremor that's been resistant to the oral medications. So if they really haven't seen a response from the pills that we've tried, we can, you know, utilize DBS for the tremor, but we also use it for people that are in that mid to more advanced stage of Parkinson's where they're having the ups and downs, the medication fluctuations. And DBS can also help to reduce off time. And usually because we're able to reduce, not necessarily discontinue, but because we're able to reduce medications, it can also reduce dyskinesias. So there are two targets that we utilize, the subthalamic nucleus and the globus pallidus interna. And those are just two deep areas of the brain. You can kind of see the photographs there, the drawings there, showing you the GPI and the STN. They're deep areas of the brain. They're part of the basal ganglia, which are the parts of the brain that are most impacted by Parkinson's and that loss of dopamine. And the latest updates with DBS, so we use in our center, we use Boston Scientific and Medtronic systems. And both of those now have directional capability, which, the procedure for the individual, for the patient receiving the procedure, it's the same. On our end, when we're trying to program the device and, find a setting that works well for a patient without causing side effects, that directional capability is key because it just gives us more options. It actually, like basically with this procedure, we are the electrode, we're creating an electrical field in the brain. And we are, in essence, we're kind of blocking some of the abnormal signaling there in that deep part of the brain that leads to Parkinson's symptoms. That electrical field, it needs to target like a very precise area in order for it to work, but not cause, side effects. And with the directional stimulation, we can actually sort of like bend and shape that electrical field more precisely the way we want to, just for better symptom control without side effects. So that's been kind of a key upgrade, I think, on the technology. The next step is also likely going to be the development of this closed loop technology. So right now with deep brain stimulation, the doctors program the system, like I said, and then we kind of, we set it and we leave it. And while the patient may have the capability to make some minor adjustments to the system, like to go up slightly, like on the power and that sort of thing, like for the most part, like I said, we set it and we leave it, and it, is operating that way 24/7. It stays on and it's operating 24/7. With closed loop technology, the idea is that the electrode would actually be able to sense what's happening in the brain. And actually pick up on these frequencies that are associated with symptoms. And when it recognizes, those signs, those frequencies that are associated with symptoms, then maybe actually be able to turn on or to change, stimulation pattern in response to that. So it's kind of like a smart system that actually knows what's going on in the brain at any given time. So that's kind of the next phase. Another option that, so this is like a potential alternative to deep brain stimulation. Another option that I get asked pretty frequently about is this thing called MRI guided focused ultrasound. And that is an ablation procedure. So it's non-invasive. It does not require surgery, but it does ultimately result in permanent damage, or like a lesion is what we would call it. So a little permanent area of damage in a particular area of the brain. And in this case, they're using ultrasound waves. There is a similar procedure that also can be done called gamma knife radiosurgery, where instead of using ultrasound waves, they use radiation to achieve that little area of damage in a part of the brain. Right now, this technology is FDA approved to treat Parkinson's tremor only. And that's because they are targeting for this, actually the part of the brain that we would typically target for essential tremor patients who are getting deep brain stimulation. So it's called the VIM. It's an area within a part of the brain called the thalamus. And so this is like the essential tremor location. It does not address the other symptoms of Parkinson's, like bradykinesia or rigidity. It's only going to improve tremor. So, for patients who have tremor as their predominant symptom, or especially, I guess, who have a one-sided, a unilateral tremor that is their predominant symptom, this may be a good option if they're not interested in surgery. For people that have, a variety of symptoms who do have significant bradykinesia or rigidity, this is probably not going to be a good option for them. The other big limitation at this time is that it can only be done on one side of the body. So, if people have severe bilateral symptoms as well on both sides of their body, this is also probably not going to be a good option. Now my understanding is that they are evaluating the safety of doing this to both sides of the brain for both sides of the body. And that's something that, is being looked at, but at this point it's only done on one. And I made this, it may be a little bit busy, but this is just kind of a side to side, a head to head comparison of the two procedures, DBS and focused ultrasound. Like I said, probably, biggest advantages of the focused ultrasound over DBS is that it's non-invasive and there's no implanted hardware. I think the advantages of DBS over focused ultrasound are that it covers, at this point, a larger variety of symptoms. It's adjustable. It's more reversible. And the biggie that it can be actually done on both sides of the brain to treat both sides of the body. So those are, I guess, probably the big takeaways when we're trying to compare the two. And just a few research updates here. So I want to just very quickly go over the idea of these different phases of clinical research. So when people hear phase 1, phase 2, phase 3, so essentially, phase 1 are going to be a pretty small scale study, 20 to 100 patients that are either actually healthy volunteers. Sometimes they start these with just, healthy control patients, or people with the condition in question. And they're really looking mostly for the safety and the tolerability of the treatment. And, if the data from phase 1 is good, if it is safe and well tolerated, then it can move on to a phase 2. Those are going to be a larger number of people with the condition in question, in this case, Parkinson's. And they're evaluating not only sort of the tolerability, the side effects, but they're actually looking does it work? Does it improve what we're hoping it's going to improve? And again, if the results from the phase 2 are promising, if it's both, sort of safe and seems to be effective, then they'll move on to the phase 3, which is going to be also a pretty big group of patients for a longer duration. And they're going to even more closely evaluate the effectiveness and the tolerability of the treatment. Phase 4s are usually after FDA approval has been granted for the treatment, and then they're continuing kind of their monitoring, to see how people in a real world situation or more real world situation are doing with the treatment. So some big updates that we got this year. So you all probably heard about aducanumab or Aduhelm, which is the drug that was just recently kind of pushed through for Alzheimer's disease. It's very controversial, and I would say physicians have some pretty strong opinions about it. It is an antibody therapy. So in that case, and in the case of Aduhelm, it is an antibody that is targeting amyloid. So that's, the specific protein that accumulates and is associated with Alzheimer's disease. So, the same concept is being evaluated for Parkinson's, although in this case, of course, they're developing antibodies against alpha-synuclein, which is, the specific protein that is associated that we think kind of clumps and accumulates within the cells of the brain and then leads downstream to loss of these dopamine producing neurons. So we think that alpha-synuclein is key to the pathology of Parkinson's and the development of Parkinson's. So these antibodies are designed to target alpha-synuclein and, either clear it or prevent it from clumping and accumulating and gunking up the works in the brain. Unfortunately, Biogen's antibody that they had developed, and we were involved in the study at Wake, that study was terminated in phase 2 because it was not meeting its endpoint. So it wasn't showing the improvements that they were hoping to see. And in that case, it was actually given through the spinal fluid. It was administered into the spinal fluid. However, there are 2 other companies, Roche and AstraZeneca, who are also working on their own versions, like their own alpha-synuclein targeting antibodies. And those are still ongoing. So the Roche antibody has advanced to a phase 2B, and it's an IV administration. And then AstraZeneca is still currently in phase 1, but it is also an IV formulation. So, I think in the Parkinson's world, we are, we're cautiously optimistic about this approach, this alpha-synuclein antibody approach, and we're anxious to see what the results are going to be from the Roche and the AstraZeneca, versions. I think clinical research is of course extremely crucial to us advancing our knowledge just of the process of Parkinson's itself, and also being able to develop new treatments, both symptomatic treatments, new medications like Cinemet that we can use to control symptoms, and also hopefully find a disease modifying treatment that will actually slow the disease process or reverse the disease process. I mean, that's the big one that I think we're all interested in finding. And, I think if you're considering participating in research, there are just a lot of factors to consider. But it's very, very crucial to our advancement of kind of ending this disease. Very quickly, and is this, I'm assuming probably the slides will be available because they're being recorded. I wanted to just let you know about a few studies that are actively ongoing at Wake Forest. This is one that is exciting because, again, this is a treatment that we're hoping may be disease modifying, that may actually, stall or reverse, kind of remains to be seen, but the effects of Parkinson's disease. The criteria are pretty strict, the inclusion criteria, in that people can never have taken symptomatic medications for Parkinson's. So generally these have to be people pretty early in their disease course, recently diagnosed, who have not started any type of symptomatic Parkinson's drug. But the idea is that this compound that right now is used to treat diabetes may have neuroprotective effects by reducing inflammation in the brain. So the drug is called exenatide. You all may have, heard and read about it. So that's the information for that particular study coordinator, Jen Love. We also have one looking at a non-invasive neurostimulation technique. It's a little headset that people wear. And like I said, like it says here, it's used twice a day for a period of 12 weeks. It does require 3 in-person visits to Wake Forest. And in this case, people must, have the diagnosis and have been responsive to levodopa for 3 years. The idea behind this device is that it may alter blood flow or improve cerebral blood flow, and improve brain function. And this is specific to people with Parkinson's. And then the last one I think I have on here from us is a light therapy study. So this is an NIH supported study that is looking at whether light therapy is helpful for improving Parkinson's related sleep problems. And for this particular one, we are nearing the end of recruitment. Really, we are specifically hoping to enroll some individuals from more underrepresented populations because we want to make sure that they're, included in this kind of data. So specifically, we're hoping to find some individuals with Parkinson's who are Black or Hispanic. So there is the contact information for Carolina. She's our study coordinator for that particular trial. And I guess can you give me a sense of how much time I have, or should I basically be wrapping up at this point, Anne-Marie?
You should be wrapping up at this point.
Okay.
Because there are quite a few questions.
Okay, well, why don't I kind of end it here? I mean, really, the last few slides were just a few things that are ongoing, like elsewhere, kind of some up and coming things with research. My last little plug before I take questions, I think, is, if research is of interest to you, I would definitely check out clinicaltrials.gov. So clinicaltrials.gov is, basically the repository for ongoing clinical trials that actually in this country and internationally. And it allows you to search by specific terms. So you can search by Parkinson's disease. You can sort by the trials that are actively recruiting for patients and see what's out there. And that's a really great way, to find out just what's available. And it usually provides contact information for the coordinators of those studies where you can directly reach out and express your interest. All right, so.
And I do want to let everyone know that Dr. Tate, if it is okay with you for us to provide the presentations, we will be loading all of those on our YouTube channel. So what we'll do next week, Quincy will gather everyone's presentations. She'll load those up onto our YouTube, and everyone who registered will receive an email letting you know where to go and how to look at those, so that you can watch the recordings there. And also, Quincy will go through your presentation, and everywhere that there's a study going on, she'll add that to our October newsletter. So it'll be in there for any of the ones that are still going on beyond that. So be on the lookout, everyone, for the October newsletter to have more information about those studies.
Great.
All right. So the first one I have is someone asks, is the medication regimen different for young onset Parkinson's, or is it based on early and mid disease state?
And I'm so, could you repeat that question for me one more time?
Sure.
Sorry.
No, absolutely. Is the medication regimen different for young onset than young onset Parkinson's, or is it based on early and mid disease state?
Yeah, I would say more based off the symptom set that people are experiencing, not necessarily the age of the patient. I mean, we do know that there are differences between young onset and late onset Parkinson's. We know that there may be some increased susceptibility to things like impulse control disorders. So those are things like behavior changes, excessive spending, gambling, hypersexuality, OCD-like behaviors, things like that can come from some of the medications we use for Parkinson's. And so I think in young onset patients, we tend to be a little bit more careful with those or potentially avoid them. There's also the whole debate about when to start levodopa. If we're expecting somebody to be on it for decades, should we hold off on it and kind of save it for later versus starting it now? And I mean, there's not a clear right or wrong there, but I will say in general, I think, movement disorder experts are kind of shifting toward earlier start like giving somebody like a longer duration of kind of that honeymoon period that I mentioned with levodopa, rather than waiting kind of, waiting late to start it. So that's probably the biggest thing that comes up with a young patient, I think, who's diagnosed, is kind of debating when the right time might be to start carbidopa levodopa. But in general, yeah, we're going to base it more off like the symptom subset and what people are experiencing rather than their age. Oh, I'm sorry, I can't hear you. I think you're still muted.
Sorry, I was muting because I was talking to somebody. Sorry. Are there any cognitive issue DBS benefits from Wake Forest research? I'm not quite sure what that is.
I'm not exactly sure. There is a study ongoing evaluating deep brain stimulation for Alzheimer's disease. So looking to see whether it does benefit cognition directly. I'm not sure if that might be what you're thinking of. So that is an ongoing trial at Wake.
Okay. And I guess whether it might translate over to Parkinson's cognitive issue.
Right. I mean, I would say really early to know about that. I mean, because at this point, with the current the current brain targets that we're using for Parkinson's, those are focused on the treatment of motor symptoms, of course. There are actually some risks to cognition from DBS, and so people who are experiencing significant cognitive issues, we tend to be we tend to have reservations about doing deep brain stimulation. So, it's possible that this research might, expand us to new targets, new locations that we can go after for people that do have Parkinson's and cognitive impairment. It's just very, very early to know.
Great. Someone wanted to know whether the DBS sensor stimulator can be removed if needed or indicated, or can it just exist in the brain and be turned off?
So actually both of those things are possible. So yeah, it's rare. It's thankfully rare that we have to do that. But, if a person wants it out, in most cases it can be removed, or there are situations where we just leave it off.
Gotcha. Someone asked what the best way to test for inflammation is, and what are the key things to do to reduce it and prevent it?
Good question. I mean, we really don't have a good test at this point for that type of inflammation. Like if we're actually specifically evaluating for neuroinflammation, brain inflammation, outside of maybe some very specific research studies, but just clinically, we don't have a good way to test for that. Ways to reduce it. So far, the simple things we know about that probably have an impact are exercise, good sleep, and good sleep habits. Potentially things like the Mediterranean diet, which is considered kind of a anti-inflammatory, style of diet that also reduces risk of cardiovascular disease, and things of that nature.
Gotcha. Let's see. Somebody asked about a Lilly clinical trial that was going on for cognitive issues in PD. I don't know if you all had that.
I do. Yeah, I mean, and I apologize. I don't. So I'm pretty sure you might be referring to one that my colleague, Dr. Mustafa Siddiqui, may have had ongoing. And I apologize because I don't know what the latest update is on that one.
Okay. That's what they were wondering, whether the drug was approved or if the study was still ongoing. Mm-hmm. Okay. And then somebody asked, what was there a transdermal patch system for levodopa that went away? That's not available anymore?
Well, there is one that is still in active clinical trials. So they are still evaluating a transdermal pump. So that would be one that is a lot more akin to, an insulin pump. So it's small, it releases the drug just still being evaluated.
Gotcha. All right. Well, I think that's everything we have right now. If anybody submits anything in a little while or later, we'll definitely shoot those to you, Dr. Tate. See if you can answer those for us. I can't thank you enough for carving time out of your schedule. I know originally you had to juggle a few things, so we appreciate you doing that to be here with us today. And everyone, just if you have any questions for Dr. Tate, as I said, don't hesitate to email us. Or put them in the chat. We are recording this, so we will be able to retrieve those later and send those to Dr. Tate. And if you're interested in the Wake Forest Baptist Movement Disorders Clinic, I have to say Atrium, I keep forgetting,
Yeah.
Atrium Wake Forest Baptist Movement Disorders Clinic. There's some information on the screen.